Tonight's program is about AB 1400, CalCare. Very happy to have our Vice President Jeanna Harris and Ryan Skolnick from the California Nurses Association, who are both been great advocates for public health care in California. So I'm just going to turn the first hour of this over to them, and they will present their materials and take questions from you at some point. So I'm just gonna give them the floor, and I'll be back at 8 o'clock.
Great, thanks, Jeff. Hey, everybody. I am extremely tired, but it's all in the name of AB 1400 and getting single payer passed. As you guys know, I don't have to really go into my background being a nurse and everything. You know, single payer is near and dear to my heart. And so what I've been working on and have solely been focusing on with my very limited energy nowadays is this passing of this bill, doing any and everything I can, working closely with Senator Sidney Kamlager, and, you know, working and just newly appointed to an LACDP committee around this bill. But one thing I do when I hit a wall or I get information that I'm like, you know, I don't know what's going on, because you guys know that the Nurses Association has been the key drivers of these healthcare bills. SB 562 that came out in 2017 was very strong nurse CNA support, and now AB 1400. So when I, you know, am like, hey, I don't know what the hell's going on. What's going on kind of like up the chain. I need to know what's kind of going on the strategic side. I can educate till the cows come home. What I do is, believe it or not, there's somebody who knows this stuff a little better than I do. And so I turn to Ryan, and I'll just shoot him a quick message and be like, hey, did you know this? What's going on? What's this mean? You know? And so I thought it would be good to hear from him, because I didn't want to do, you know, I felt like you guys shouldn't have to listen to me talk for a full hour. You guys have to listen to me enough as it is. So I thought I'd bring Ryan in to really get into the nitty gritty on this bill. Most of you guys know about it. And you know about AB 1400. You know, I've been talking about it it's been lots of chatter going on around it, but I felt like he would be a good person to present, especially being a representative of the union. And so Ryan, you know, he's a community organizer with the California Nurses Association and the National Nurses Association. And I mean, he's working hard to pass this, you know, guaranteed healthcare for all for California. And he's specializing in the messaging. So you might, if you are on the email list for CNA or NNU, you might have actually seen emails come from Ryan Skolnick or Phil Kim about events coming up, one of which is coming up right up this weekend. I'm not going to be the one to advertise that, because that's his event. So I'm going to let him talk about it. So I'm going to throw it over to Ryan, who's going to get into the nitty gritty of AB 1400 and talk about why this is getting ready to revolutionize healthcare as we know it for California. And you know, if we can do this for California, we're going to do this for the entire country.
Great. Thanks so much, Jeanna. Thank you all for having me. It's really good to be here. Given all the stuff that's been going on, like working on this weekend's events, which I'll talk about more later, it's good to actually be in front of people talking about healthcare again. So like Jeanna said, my name is Ryan Skolnick, and I'm one of the community organizers for the California Nurses Association. And CalCare has been my focus since basically November, when it was just a concept and we didn't know whether there was going to be a bill at all or not. We were hopeful, but we weren't sure. But we ended up getting one, and it wasn't always guaranteed that it was going to happen. But a lot of advocacy and a lot of people doing the exact kind of work Jeanna was talking about earlier resulted in a really strong bill, easily the strongest single payer bill ever introduced in California, for sure, being introduced. I don't think I need to go too much into what single payer is, like too deep in the weeds, because from what Jeanna made it sound like you all are aware of what single payer basically is. So what I want to do is I'm going to give a brief overview of the bill, give a little pitch about it. I'm going to talk about where the bill stands and what we're focused on right now. And then I want to spend most of the time addressing questions, because everyone has different questions about single payer, about the strategy, about what's going on. And I think that all of your questions should drive the discussion. So let me give a very brief presentation about what AB 1400, or as we are calling it, CalCare is, and then where we are. So CalCare, which is the short name for the bill itself, which is the California Guaranteed Healthcare for All Act, is based on 7 core principles. And the core principles are: 1, universal coverage, everybody in, nobody out, regardless of age, gender, sex, immigration status, race, any other considerations. 2, a single public program, a single payer system publicly funded through progressive taxation to cover all necessary care in California. 3, fully comprehensive benefits, including medical, dental, hearing, vision, mental health, prescriptions, long-term care, anything that your provider determines is necessary and appropriate for you. 4, freedom to choose your care provider. No in-network and out-of-network, no limited provider networks that people have to go to. If there is a doctor practicing under CalCare, it doesn't matter where they are, you can see that doctor and get the same care no matter where in the state they are. 5, free at the point of service, meaning no cost sharing when you go to see a doctor, no co-pays for care or prescriptions. You show up to the doctor, show them your CalCare card, and get care. It's that simple. 6, a just transition, funding and programs, at least 1% of a multi-billion-dollar budget for the first 5 years to support and help transition anyone who works in an industry that will be disrupted by the transition to CalCare, namely the insurance industry. And then finally, patient care based on patient need. CalCare eliminates a lot of the financial incentives that exist in our current system that result in the denial or reduction in care, including value-based payment models and providers acting as insurers. CalCare creates it to where the job of a provider is simply to provide care. And that is all that comes down to. Those 7 core principles define CalCare. And that is what is the essence of a true single payer system that will guarantee healthcare to everyone as a human right. So that's what CalCare is based on. And I want to talk really quickly about where CalCare is in the process, what things are looking like right now, and what we're doing to advance this bill forward. So CalCare as a healthcare bill has to go through 2 separate committees of jurisdiction in each house of the state legislature. The policy committee is obviously the health committee. The bill as an assembly bill, AB 1400, is in the assembly right now, and it needs to go through the assembly health committee. And then as a bill that would appropriate money, it needs to go through the appropriations committee. And then it needs to be passed on the floor. And then it needs to go through that same process in the Senate. So that's the path the bill needs to take. Right now, the bill is currently being scored by the California Health Benefits Review Program, or CHBRP, which is kind of a funny name. But that is essentially a policy and institute that is on call from the legislature to score bills that would change health delivery in the state. So it is currently doing a score of AB 1400 and will deliver that to the legislature on the 21st. Now, the thing that we're up against here is time, because bills must clear their policy committees by the end of April for them to be heard and for them to advance. If they're not, they become 2-year bills, which means that they can be heard again next January, but they can't advance until then. That gives us a little over a week from the time the legislature receives the CHBRP analysis for them to schedule a hearing in the health committee and for it to clear the health committee. And then it needs to clear appropriations not far after. So we are up against a tight time limit, and we are working hard to get the bill a hearing, which is why we're doing these weekend activities that I'm going to describe in just a minute. But there is a chance that the bill will not be heard in the health committee prior to the end of the month, because the CHBRP analysis is going to be cutting it very close. In which case, that's totally fine, because our perspective is, in the event that we can't hear it until January, that's a full year for us to organize and build support to get CalCare passed. And that is at the essence of what our campaign is focused on right now. Building a movement, a grassroots movement, which composed of people like you and people all over the state of California. And the reason for this is, well, single payer is overwhelmingly popular among Democrats in the state. In fact, we just commissioned a study that showed that even when presented with the negative arguments about single payer, 85% of California Democrats still support AB 1400 specifically, or CalCare, which is really cool. But the problem is that we have a lot of very powerful entities that don't want single payer because it wouldn't be very good for them. The for-profit insurance industry would essentially be eliminated under CalCare. And while that's not a bad thing for us because they don't really provide anything positive in our healthcare system, there are a lot of really wealthy stakeholders that make a lot of money off of our premiums, and they don't want that arrangement to change. The prescription drug companies don't want to have to negotiate with the entire state for everyone's drugs because the state has a lot more negotiating power than one provider, meaning that the drug prices would go down a lot. Great for us, not so great for them. So there's a lot of powerful opposition. In fact, they've already formed a front group, the Orwellian titled Californians Against the Costly Disruption of Our Healthcare, which is a group that exists by its own admission solely to block single payer in California. I call it Orwellian because there's nothing more disruptive than someone getting sick and suffering because they can't afford to see a doctor, which is our reality right now. So we're focused on building a movement throughout the state of California to be essentially put more pressure on our legislators than the powerful industries that oppose us can do. They have more money, but we have people. And we've been doing that in a few different ways. The first is a series of events that we're doing this weekend, and they're called CalCare Speakouts. So the idea behind CalCare Speakouts are essentially car rallies. What we're doing is, in the lead up to the release of the Chubbuck analysis, we want to show that there is a lot of energy and enthusiasm for guaranteed healthcare for all in California. And we are doing car rallies. They're socially distanced, people don't leave their cars, done by conference line, car rallies in 18 different cities in the state of California, 5 of which are bottom lined by CNA staffers ourselves in key districts of Democratic members of the Health Committee in the Assembly that have not yet signed on in support of the bill. The bill was introduced with 18 original co-sponsors, which is great and far more than we had when SB 562 was introduced. And 5 of them sit on the Health Committee, which is great, but we need 8 Democrats to vote for the bill in order for it to move forward. So that's why we're focusing especially on these particular representatives, but we're doing them all over the state because we want to show that there's support everywhere for CalCare. We're also doing phone banks, which will be starting on the 20th, where we're going to be calling people in those districts, asking them to call their members of the legislature and ask them to call for a hearing on AB 1400. We have a movement builders program where we are training people through calls like this to have one-on-one organizing conversations with people in their own personal networks, how to turn them from passive supporters of guaranteed healthcare for all into active members of the movement. Because while 85% of California Democrats say they support guaranteed healthcare for all, only a very small percentage are actively doing something to make it happen. Taking that passive support and turning it active is a critical part of the work we are doing to pass guaranteed healthcare for all. So that is what we are focused on right now as the union is the primary organizational sponsor of the bill. People all over the state are doing a bunch of other events as well. DSA is doing some canvassing, for example. We have people who are trying to meet with their legislators directly themselves to talk about the bill. People are doing great work throughout the state of California, and it's very encouraging right now. But obviously, we have a lot of work to do. So that's what I wanted to talk to you all about tonight. And then, like I mentioned before, I want the majority of our conversation to be driven by you all in the form of questions you may have about the policy, the strategy, whatever it may be. I'd like to be able to answer any of those questions. So I wanted to keep my remarks relatively short. And with that, I don't know if Jeanna wants to moderate this portion or if she wants me to just call on people, whatever works best for you. And we can take
So I'll go ahead and, yeah, if you guys, Jeff made me a co-host, so now I can see the hands. So if you guys raise your hands, I'll just call on you. I'll just kind of use the hands as a stack. If you do not have the ability to raise your little blue hand, then just write, stack in the chat. And I will, add you in there. Okie doke, and look at that, all the little blue hands. It's Smurf Nation over here. All right, so first question, and thank you for giving so much time for questions. Usually we run all the way to the end and only can take a few, and I know this is gonna have some really, good question and answer. So Tom and or Ronnie, you were the first one with your hand up.
What is the reason that we do not have healthcare in this state right now? I mean, what is the biggest thing that we need to knock down? Is it because they don't think we have the money? I don't really understand why we're not being able to get over that hump, over the objections. So where do I put my my forces to knock down something that's making it very difficult for us?
That's a fantastic question. And I have a very quick 3-word answer: for-profit healthcare. The reason why it hasn't happened, going all the way back, has been their influence, whether it was Prop 186 in 1992, which was a CNA-led ballot initiative that would have implemented guaranteed healthcare for all through single payer in the state. That was beaten by a barrage of misleading negative ads from the insurance and drug companies. SB 562, people love to blame one particular legislator, the speaker, for 562 being shelved. In reality, there was a group of Democrats in the assembly that didn't want the bill heard. And essentially, that was the source of the bill being shut down. So it's not one particular person or entity's fault. There's a ton of money to be lost here, and that means there's a ton of pressure from people who don't want the status quo to change. So building a movement that puts more pressure on our legislators, positive high road pressure, but pressure nonetheless, than the money of the insurance companies can, is how we win. Because at the end of the day, the reason they're spending so much money is, and the reason why they're so powerful, is because their legislators are afraid that if the insurance companies turn on them, they'll lose their seats. But that threat loses its power when the people have a stronger pull, because people are mobilized. So that's the answers. We got to continue to bring more people actively into the campaign, calling our legislators, putting pressure on, and that's how ultimately we're going to win. We weren't strong enough for 562. We want to be strong enough to get this done.
Can we get the list of names of those that voted to shit can it?
So, I mean, can I add to that? So right now, the key authors like Assemblymember Ash Kalra, Miguel Santiago, Alex Lee, everyone is basically like, they're telling us be nice. And so while it is okay to express that you are wanting this bill to pass, I've been, trust me, trying to keep the grassroots progressives in check too, from going complete ape, just crazy, because especially with the timeline being so tight, they're already thinking there's shenanigans afoot. And so right now we're still kind of in this exploratory phase. We do not know who an enemy might be, and I don't want to attack a potential ally. So I will say right now, the best thing we could do is put pressure on the health committee by letting them know, hey, we want this bill, but not in a negative way. Even if we know that they take big insurance money, if we know that they're vehemently against single payer, we're still not going negative on them yet, because they could be a potential ally. So that's kind of where, where we're at, like when it comes to like pressure, and we're trying to play nice. We just want them to know we want this bill. We want them to hear it. We want it to have its fair shake. No tabling, no putting it to the side, no asking dumb questions, because we've got the answers to all the questions. And as you see, Ryan has that in depth. So I'm going to go to the next one.
So they never are nice to us, just so you know.
No, they're not. But what's that old school, two wrongs don't make a right or whatever, until they make me really mad. Then when I blow the whistle and say let's go, it's because there's no other way. So to be continued on that one. Daniel, you're up next.
Hey Ryan, thank you. My thoughts are kind of along the same as Tom. You mentioned that the last time we had single payer, bill happen, it got squashed by a group of people. But I distinctly remember Anthony Rendon being the one person that stopped it in committee. So, how does this bill differ from the last bill, and how do we expect, with a legislature full of people like him, how are we supposed to, like, what's different about this one that's going to make it happen? I mean,
that's a great question.
Yeah.
So that's a two-part question. The first part about, wasn't it Rendon that shelved the bill? It absolutely was. As the speaker, he's the one who made the decision that the bill would not be referred from the Rules Committee to the Health Committee for a hearing.
Yeah, so I don't want to give him a pass on that and say it was other people. I mean, maybe he was pressured, but he did it. So.
Well, I don't think it's as much of a matter of giving him a pass as it is acknowledging the way the assembly works, in the sense that if it weren't Rendon, whoever would be up next would do the same thing. The expectation of the leader of the Legislative Caucus, the Democratic Assembly Caucus, the Democratic Senate Caucus, is that they do what they can to protect their members. And there were a lot of members evidently went to Rendon and said, we don't want to vote on this. This is going to be bad for us in our districts, blah, 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 which I probably don't think is true, but that's what they said. And Rendon did what he was supposed to do as the leader, which is be the one who made the decision on behalf of those in his caucus who didn't want to vote on it. Now, that doesn't mean that we give anyone the benefit of the doubt, but what it means is we acknowledge that addressing one player won't get us the win. We need to focus on the people who led to Rendon making that decision, because even if Rendon decides, okay, I'm not going to be the face of the person, the face of the one who kills the bill, there's a ton of ways for a bill to be killed in the legislature, and any number of people could be the one at the face of it. But this institutional issue, not being enough support yet, remains the same. So that was the point I was making, is that while Rendon did shelve the bill, we have to do more than just pressure him if we're going to get this through. And as for what's different this time, there are a few different things. First is the bill itself. This bill is improved in every way, shape, and form over SB 562. For example, it's almost 3 times as long. It's far more detailed as far as the implementation of the bill, of the role of the governing board, how exactly doctors are reimbursed. A lot of those policy objections that Rendon gave last time have been addressed in this first intro of the bill. The bill essentially takes the national Medicare for All bill, which is they're the strongest bill that's ever been introduced in the country, and adapted it for California. So it's much more implementation ready than the prior bill was. So that's solved a lot of worry right there. And also, the thing is, Rendon himself has called himself a supporter of single payer. And like Jeanna said, we want to give people the benefit of the doubt this time before we immediately assume that they're the enemy. Once they out themselves as an actual enemy, then we can strategize like that. But right now, we have supporters and we have silence. We don't have a lot of no. So we want to give people the chance to do the right thing before we escalate, is where we're at right now. But in addition to the bill being stronger, we also think that the appetite for single payer has grown in California. The polls have shown it's continuously popular. This bill was introduced with far more legislator support than 562 was. So I think that the calculations changed, but the only question is, has it changed enough? And that's what we're working to make sure of by building this movement, if that makes sense.
Awesome. Thank you for that. And yeah, I think actually I was on a call on Sunday with Miguel Santiago, and he specifically talked about, Rendon too. And he was like, he has spoken directly to Rendon about how he's like, interested in the bill. He's not, and he's of course supports single payer. Like I said, we take everything with a grain of salt, but right now it's like, okay, well, if you're gonna, my thing is, it's like we can disagree on a lot of things, but if you're gonna ride with me on this, you're gonna ride with me to the end, all the way to the end. So I said that to all the co-authors, authors, principal sponsors, everyone that's on that bill. They're not allowed to back down, including our very own senator. Like I'm riding with her to the very end. We're going to the wheels fall off on this bill because yeah, like you put your name on it, you're owning it. All right, so next up we have Kinkin.
Thank you, Jeanna. Appreciate the opportunity. First of all, I just wanted to say that as a practicing physician, I support AB 1400. But of course, my brain automatically goes to comparing it to SB 562. And okay, going back to AB 1400, we know that it's going to be financed by an amalgamation of CHIPS, Children's Health Insurance Program, Medi-Cal, Medicare, and Obamacare all added up together. And what is the mechanism, I guess, that will allow us to pull funds from all the above? So what do the legislators have to do to pull everything together to finance it? I remember with SB 562, the bill came to like $400 billion a year. So the question that comes from that is, do we have enough in the kitty to finance it from the get-go? So that's the first question, I suppose. And the second question is, I'm currently a Kaiser member, and I'm curious as to what happens to my Kaiser insurance. And I see Cynthia nodding. Yeah, when AB 1400 rolls into town. So if you could provide answers to those questions, I'd appreciate it. Thank you.
So those are questions we hear a lot, and that's something that I've worked really hard to make sure that we can communicate in a clear and concise way, because these are confusing issues and they're very common. So for your first question, I'm going to start with the quick answer, and then I'm going to give you an explanation. The quick answer for how we consolidate them is to start by passing AB 1400. And here's why. The process for consolidating Medicare funds, Medicaid funds, ACA pass-through funding, all those different things is through a set of Health and Human Services waivers, where the Health and Human Services Department of the federal government can allow states more flexibility to use money for healthcare that normally would be earmarked for a very specific thing. Mm-hmm. And there are multiple waivers that the state can apply for, and they can do it all at one time through the ACA. Mm-hmm. And here's what that process looks like. Once California has a single payer bill on the books, namely it's been passed by our legislature and signed into law, then the bill itself directs the new CalCare board to apply to the federal government for all waivers necessary to consolidate funds. And that will take a few different forms. For example, Medicaid, the money that we are given for Medicaid could likely be put directly into the CalCare Trust Fund. Mm-hmm. Medicare, we can receive some money, but we can also be an actual provider of an actual administrator of the Medicare program, which would allow us to align the benefits program of Medicare with CalCare to make sure that it's a seamless program, a single payer. And then ACA, it allows us to waive the requirement of having exchanges because they don't make sense on a single payer system, and pass through federal subsidies into the single payer system. And that can all be done in one process. But that process can't go forward until AB 1400 is signed into law, because the Affordable Care Act and HHS guidance requires that if a state applies for those waivers, it has to already have legislation on the books authorizing the program they're applying for waivers for. So once we pass and sign AB 1400, the board that the bill creates will apply to the federal government for all necessary waivers. There's a public review process. We have to make sure the bill meets certain requirements. For example, it can't increase the federal deficit, and it needs to cover at least as many people as would be covered without them. And if it meets all the requirements, the government will enter into a contract with the state. So that's what the first process looks like, consolidating federal funds.
Okay.
The second question regarding Kaiser is, long story short, your actual care won't change. And here's what I mean. Kaiser is an example of an entity that both provides care, also provides the insurance coverage. Kaiser wouldn't exist as an insurer anymore, but it would still exist as a provider. So you could still go to Kaiser and see the same doctors and be part of the same program. The difference is, instead of Kaiser itself paying your doctors, the single payer system would pay the doctors. And as well as being able to see your doctor through Kaiser and stay within that system, if it turns out that Kaiser doesn't have an available provider near you that covers a certain thing, you can go outside of the network now because you're no longer in that ecosystem or trapped in that ecosystem. You can choose to stay in it, but now you have the ability to go see someone else. And I want to address really quickly, because I saw a question on this note, so I might as well address it all at once, in the chat from Cynthia about Kaiser Medicare Advantage. So the bill, so first, as a state, we don't have the ability to snap our fingers and make federal insurance programs disappear, like if this were being implemented at the federal level. So here's what it would look like for people who are on Medicare in some form or another. First, the single payer system will not directly pay an insurance company under Medicare Advantage. So you have the option of either enrolling in standard Medicare or pay your premiums to Medicare Advantage. And then the CalCare system would essentially become your Medigap plan, where it will cover all, and here's what I mean by that. I don't mean that it's going to cover the same thing Medigap does. I mean, it's going to replace the need for it. And here's what that looks like. Say you're on public Medicare, which covers 80% of services and doesn't cover everything. Medicare would cover all of that. CalCare would then cover your Medicare premium and the 20% that isn't covered by Medicare and any services that Medicare doesn't provide. So essentially, you would have full coverage of all benefits just like you would under CalCare. The difference being, of course, that you're still receiving the care that Medicare can provide from Medicare, because states don't have the authority to just snap Medicare away. So in a sense, it would look the exact same to you. You can still go to see any doctor and get the care you need. Difference, of course, being that in the back end, it's going to look differently because that's where all the alignment's going to be. So essentially, nothing's going to change except for the fact that you're getting all the benefits paid for by two different doctors. Because it's important to understand that there's a difference between liking your coverage and liking your care. Everyone loves their doctors, their nurses, their practitioners. Those things don't change under single payer. The only thing that changes is who pays those doctors. So for you, the only thing that changes is if you don't have the ability to see a doctor now, you'll be able to under CalCare because there are no networks. So hopefully that answers those questions.
Thanks, Ryan. Appreciate it.
Thank you, Ryan. Yeah, that's really good. I mean, like I said, it's single payer, not single doctor. So trust me, a lot of doctors have headaches. I deal with Medicare Advantage. You guys know I don't talk too much about my work because it's kind of conflicting with what I do. But you know, under single payer, my job goes away. And it's a high paying job, and I'm okay with that. Why? Because I don't like what I do. I don't like having to deny. I don't like having to reroute care for cheaper providers or anything like that. To me, it's a disservice. But it pays my bills right now, so I'm doing it. But it's also given me a very good insight beyond what a lot of people have when it comes to you know, navigating this insurance world, Medicare Advantage especially. So, you know, I like to share that story because, you know, people think that, you know, there's just a bunch of activists here who don't really know what's really going on. I'm like, I know exactly what's going on and I'm still wanting to get rid of it. So, you know, that's just my little 2 cents on that. But the doctors they like the words fee for service and global budgets, trust me, because a lot of times Medicare Advantage negotiates rates lesser than the actual full 100%. And so, you know, when that means they don't get paid the full amount that they potentially could pay, when under CalCare, we're negotiating global budgets or letting them bill as for fee for service. So they're getting paid better and a more appropriate, which means they're going to be happier providing care for you. So it's kind of a good situation for the patient and the provider. All right, next question is going to Kimberly. I know thank you guys for patiently waiting. I know these answers have been long and lengthy, but this is really good stuff.
No, it's actually great because part of it was just answered in the last one, because I'm curious as to how all of this will be funded. And I assume that in the AB 1400 bill, you actually break down the budgeting and what you foresee as the costs to create this new single payer program. And if so, who's going to run it? Is it actually sustainable?
Great questions. So the way the bill is written right now is that you have a CalCare board who is composed of appointees of the governor, the assembly speaker, and the Senate Rules Committee. And then you have the Secretary of Health and Human Services serving ex officio. And they all are required to have certain experiences in the healthcare industry, like a wide variety. So you're going to have an advocate for patients, you'll have an advocate for physicians, you'll have a registered nurse. So they're required to have a diverse range of perspectives on the governing board. And there's an advisory board on top of that with an even broader depth of experience to help advise policymaking. So they're the ones who are essentially in charge of administering the program. As far as budgets go and how CalCare allocates things, the way it's going to work is the bill won't actually take effect until the State Secretary of Health and Human Services says that we have the revenue needed to implement the program. So that gives the board enough time to calculate based on current health spending, because by the time the bill passes, it's the cost of care and everything isn't going to look the same as it does today. So rather than locking that set in stone, we're essentially saying while the financing mechanisms of the bill, and I'll get to that in a sec, are taking effect, the board is going to be tasked with preparing that budget based on the current numbers to implement the bill. So that's why it's not codified yet, because if we codified it and then the cost of care substantially increased next year or the year after, and we're kind of screwed. So that's the thinking behind allowing the board to do that. Now, as for actual financing, the federal government pays for around 50% of healthcare spending in the state of California. Mm-hmm. So assuming we're able to capture all 50% of that, we still have to raise the remainder of it.
Yeah.
Now, it's important to understand that, for example, it was mentioned that the estimate of SB 562 was it would cost $400 billion. I'll tell you right now that AB 1400 will likely be even more because it covers long-term care fully, which SB 562 only partially covered. So that's a good thing, but it also means that we're going to need to raise the revenue. The bill specifies that the revenue will come in separate legislation. And the reason for that is that there have been 1 million different financing proposals for single payer out there over the last decade or so. For example, the Pollen study on SB 562 proposed a 2.2% gross receipts tax with exemptions for the first million and a 2.2% sales tax with exemptions on necessities. Then you had Bernie Sanders's financing proposal for the national bill, which is a 4% payroll tax paid by employees and a 7.5% paid by employers, with exempting the first 30K for workers and exempting the first million for businesses. So there are a ton of different financing proposals that have been put out there, all with different benefits and drawbacks. For example, a sales tax would help alleviate the free rider issue that people like to bring up, where people move to California specifically to get care. On the other hand, it's regressive and would hurt lower income people more than higher income people. So that's why the decision was made to focus on a separate bill unique to financing, and that process is currently being worked on by stakeholders right now. I don't know when exactly the fruits of that will bear, but they are working on a separate bill specifically for financing. The idea being that this is such an important part of the bill that it should be separate from the policy. We know the policy of single payer is right. We just need to make sure that we do financing the right way, in a way that as many stakeholders as possible can agree is the most sustainable. So that's my long, wonky way of saying, we know we can finance it. We're just trying to figure out the right way right now.
So how do the hospitals fit into this? Are they privately owned still and just coming to the single payers for their funding, or how does that work exactly?
Exactly. So right now, hospitals are paid in a myriad of different conflicting ways that actually disadvantage hospitals in medically underserved and rural areas. They're driven by things like outside investment, foot traffic, all sorts of metrics that benefit larger hospital chains like Kaiser. Whereas the smaller ones are not only suffering, a lot of them are shutting down and getting bought up by the bigger ones. In fact, nationally, I think it might be, I think it's roughly equivalent in California, a quarter of rural hospitals in the entire country are at risk of shutting down because of the way we're financing hospitals right now. So what AB 1400 would do is it would leave ownership where it remains. We don't force them to become public or whatever. We just change how they receive their money to what Jeanna mentioned earlier, which is called a global budget. Whereas instead of this myriad of different financing proposals, each different institutional provider, as they're called, would negotiate with the single payer system for a lump payment to cover all of its operating expenses. Those operating expenses will be tailored toward each individual hospital and would take into account things like the services they provide, how many people go through it, the area, the health risks of the area that the hospital is located in, all of that. And on top of that, the AB 1400 creates two other budgets in addition to the global budget to supplement the global budget. One of them is called the capital expenditures budget, which is meant for the upgrading and modernizing equipment aspect, because we don't want money that's going to care being used by the bigger hospitals to buy the latest and greatest equipment. We want them to be going to actual care. So we have a separate budget for that, so that way we can prioritize hospitals that need the upgrades the most for that money. And then you have a special projects budget, which is meant to help areas that are rural and medically underserved fill in gaps that they may need. For example, rural hospitals could use it to hire more staff, or it could give their doctors a pay raise, which would incentivize more doctors to move to rural areas where we have the biggest provider shortage. So they will remain privately owned if they're currently privately owned, but they'll receive their funding from the single payer system. Like I said, the delivery of care doesn't change. It's just who pays for it.
Oh, thank you.
Yep, and of course, I have to add my 2 cents. So what I did, because people want to know, how much am I going to pay? That's what people want to know. That's the question I get. How much am I going to pay? And of course, we don't have that direct answer right now. Why? Because AB 1400 is literally a key of multiple keys that have to go into the single payer door to turn the lock, to unlock single payer, honestly. But I did calculate my personal expenses of how much am I paying right now in healthcare with my employer-sponsored healthcare, and it roughly added to about 6% of my total income. Kind of gauging that I would have maybe an urgent care visit or a specialist visit at some point in time during this year. I don't know. I might be getting some roller skates, so I might need to add an ER visit into that too. What skating seems so fun. So I said, okay, 6% of my total income, right? But I also now that's 6% on top of me paying for Medicare, on top of me paying for Medicare, all the other state funded programs I have to pay. So I'm paying for two already. So why not just remove one? So if I'm paying 6% and they're saying, well, my taxes I may have to pay maybe 4%, I'm still coming out on top, in my opinion. So I know that's really barely, I don't have a lot of data and I can't say that's really factual, but that's just based on some calculations I did to kind of give people a little bit of a rough estimate about what's going on. Because of course, the naysayers will be like, your taxes are going to go up. And you're like, that may be true, but let me tell you, I'm already paying enough right now. And I didn't even go roller skating yet. So I might be actually paying a little bit more. All right.
Wait, really quickly,
sure, go ahead, Ryan.
A few quick things. With 562's financing proposal that I mentioned earlier, and the people who are working on financing are trying to keep the impact around the same. The only people who would pay more of a percentage of their income for healthcare under the 562 financing proposal would be the top 10% of income owners in the state of California, and their costs would increase at the largest by 1.9%. So even among the most wealthy, they would pay more, but barely. Everyone else would pay the same or less. So that's what it would look like in the real world. And then finally, too, it's important to understand that we're not having to raise new money per se to pay for CalCare. We're just shifting where it's coming from because our current system costs more. For example, back in 2017, when they released that $400 billion number, at the time, our healthcare system cost $425 billion. So it's like, yeah, the amount you're going to pay in taxes may occasionally go up, but the fact that you're no longer paying premiums, co-pays, or deductibles make your entire costs go down.
So I know we're down to our last 10 minutes, so I'm going to go to Rick and or Rebecca. I don't know who has the question. The Tuttles.
I'm the one. Actually, it's two things.
Sure.
One, that it occurred to me that large companies who probably pay a portion of the medical insurance for their employees, if it, depending on how the funding is actually done, their expenses could conceivably go down. I don't know if that would be the case or not. If their expenses would go down, and that's multiplied by many employees, then conceivably you could get companies, I'm not talking about health insurance companies, but other companies actually on board supporting the bill. I don't know, I'm making this up, but it sounds good to me. So that's one thing. And then the other thing is, we've been talking about those of us who are employed, paying a certain amount of money into the system. But what happens to homeless people? Can they be covered 100%? And how does that work?
Great questions. So the first one about businesses, the 562 financing study that they did showed that every size business, from smallest to largest, would either pay the same or pay less than they pay. The same being if they didn't pay anything at all. And if they did pay for care for their workers, every size business would pay less. Now, that's before you get into it, if the fact that there are some companies like the Googles and the Apples, the giant multinationals that don't care. They want the current system to exist because it's a form of social control. They can command the best, if they offer the most benefits, they can get the best talent. So even though they pay less, that's not as important to them. So it's important to know that there are some businesses that even if they'd save money won't be on board, but many will, especially small businesses who wish they could offer their employees health insurance. This is also great, by the way, for unions, because that's one less thing they have to negotiate when they're at the bargaining table. So that frees up a lot of negotiating capital. Now, as for people who are unhoused, they would 100% get full coverage, and the board would be tasked with coming up with a mechanism to do that, whether it's setting up offices and liaisons to make sure that they get the cards they need and are informed of the new program, whatever it may be. But yes, you don't need an actual address. You just need to be a resident of the state of California, regardless of any other considerations. So they would be 100% get care. It's just a matter of making sure that they know about the program and have the ability to get the card they need, which of course is a challenge, but it's not impossible. I know we can do that.
Awesome. And so I always have the saying when it comes to talking to more conservative people about this. And, I always say, look, healthy people equal productive people. Productive people equal your GDP. How about that part? And so, the thing is that, okay, I see this a lot, people get small injuries that have to fester because they don't have coverage or their coverage is limited. They cannot afford it to go to the doctor because of the co-pays or the deductibles. And that festering foot, whatever, that small wound becomes a big wound. And long story short, they could lose a foot. And now for the rest of their lives, they're getting paid disability versus them paying taxes into our country, in our society and funding things. Now we're paying for them or having to pay because, they just could not afford that one deductible, that one copay that would have went to that doctor's visit to get that taken care of. And so that's how I paint the picture that truthfully, this is a conservative measure. We are conserving money on the long term. We're just asking them to boot up and shut up and invest. I will not go to Vegas with a Republican because they're too damn cheap to come to the roulette table with me because I know I want to make big money and big money costs big investment. So that's how I look at it. I flip the script on the Republicans really fast. And so we're going to come to our last question. We're going to turn it back to Tom and Ronnie. That's the last little blue hand I've got.
Yeah, this time, and assuming this bill goes up the food chain and gets now to the governor's office, first of all, do we know how the governor feels about this? One, and two, is this something that will give progressives some leverage, perhaps, particularly in an era where I think that the governor needs all the progressive support he can get.
Because he's under a recall.
He's under a recall, yeah.
Right. So when he ran for governor, he was a strong supporter of single payer. In fact, he went in front of a bunch of delegates at the 2017 California Democratic Party convention, and a bunch of delegates asked him, 562, where are you? And Newsom said, 562, I'm with you. So I thought that was a really heartwarming moment. And he said he was on board. Now, since he's gotten elected, he hasn't been as warm when discussing single payer as he was when he was running. So we don't know. He hasn't said anything against it, but he has given the whole, we need to make sure that we can do it from budget. We need to make sure we're staying within our means, et cetera. It's stuff you expect the governor to say. So that's the first part. And I wouldn't speculate as to how this would impact the recall, only to say that I think that single payer is going to be much less feasible if Newsom were recalled. So I want to say that I don't think there's a world in which the recall goes forward in which this is good. So I don't know what that means for leverage, but I know it means that we can't allow a Republican to replace Newsom, because right now we're at a maybe with Newsom regarding the bill. We'd be at a no with anyone that would run against him, because I don't anticipate any Democrats, like Bible Democrats, running in the runoff that would be able to win in the event he was recalled.
So yeah, and just to add, I think one thing I've learned from SB 562 to now is how warm the electeds will be. Like, I feel like, honestly, I call it the Bernie bear hug. You guys, I mean, if you were part of that movement and going to those rallies and everything, you really felt that love. Like, it was wrapped around you like a bear hug, right? Like, it was just like such a warm and fuzzy moment of my life, like Woodstock in a sense. So I want to say that we have to show that love, that bear hug, to all these electeds that are going to be, in a sense, challenging the status quo. And we have to show that we're going to have their back. And so right now, even with Gavin, and I know he's got a lot of pressure, and I wouldn't want to be him. You have to deal with wildfires, a social justice movement, and COVID all at the same time. I think there's not enough Xanax in the world for me for that. So I think we just have to give him a bear hug and say, look, we've got your back. If you pass this, we need you to have our back. If you want us, if you want us to have yours, but we will give you a bear hug of support. And, like I said, I'm not trying to make enemies right now, but I just noticed that I've just gotten so much warmth from a lot of elected officials that I didn't even know that even knew my name, for one. Just because they were like, you're cool and I can talk to you and you're rational. And I was like, okay, great. This might be a good way to go. So with that being said, we're in the last 2 minutes. I just want to thank you, Ryan, so much for coming and really going in depth and answering all the questions. And if anybody, is it okay if we drop your email in the chat, your contact info, if anybody wants to reach out? I know I bug you all the time, so you guys can always ask me as well if you have questions. But also, I want to let you know there is a CalCare Speak Out, one of the CNA sponsored ones, happening on Saturday here in Culver City at the Westfield Mall. Or if Fox Hills, I don't know why I said Westfield. Who calls it Westfield? But it is the Fox Hills Mall. And it's going to be on the dining deck, the parking lot deck out there at 1 p.m. on Saturday. So I put the link in the chat earlier. I'm going to drop the link one more time for you guys to sign up. Like I said, it's right there in the backyard of Culver City. So I hope to see you guys all there on Saturday. It is supposed to be in your vehicle. And the instructions are going to be there. You'll be able to hear people through the radio. It's, we're getting a little bit past the old, megaphone days. We're getting tech savvy. So I'm going to drop that. And once again, Ryan, thank you so much. I really do appreciate you dropping in and really getting into the nitty gritty with us on the AB 1400.
Thank you, of course. Thank you all for having me. And really quickly, your MC for the Culver City Speak Out is going to be Mari Lopez, who is an organizer with CNA. She's amazing. Really, and it's going to be an amazing event. Just make sure if you're going to show up, if you have CalCare stuff, decorate your cars beforehand. If not, we'll have a bunch of placards and signs and stuff, and we'll actually come over to your cars while your windows are up and decorate them for you. So it's a really COVID safe way of having a rally. There's going to be an FM radio so people can stay in their cars and hear the broadcast. It's just going to be a really cool program. So I highly encourage everyone to show. And again, thank you all so much for having me. I love talking about this stuff, and I'm really glad that you indulged me as we talk about this today.
Thanks, Ryan.
Thank you, Ryan and Jeanna. And this program will be available on the club YouTube channel in a few days. So please tell your friends if they missed it, they can catch up. So I'm going to end the recording now.